Clint Mon, president of Mon Lemke. Please take it away.
Hey everybody, it's Clint Mon. I'm glad to be with you today. I get to be one of the presenters, but I get to be the ringmaster here, if you will, to introduce everybody. And we're going to go at a rapid pace. Take notes. As Lauren said, send us any questions for follow-up, and we're going to give you our best shot on what PDPM is all about from a strategic standpoint. Our first presenter is Cheryl Field, Chief Product Officer for Prime Technologies. Many of you know Cheryl. She's a professional expert in our post-acute business, and so she's kicking it off for us. So Cheryl, go for it.
Thank you very much, everyone. Lauren, can we go ahead and get the slides up in our visual show?
Yes, of course.
Thank you, Clint. While Lauren's doing that, let me introduce myself. Thank you very much. It's a pleasure to be here today. As Clint said, I'm Cheryl Field. I'm the Chief Product Officer at Prime Technologies. I'm also a nurse with almost 30 years in the post-acute space. So for me, looking at a new payment model, maybe for many of you, is at least something new for a change. No doubt, many of you have been following what's been going on in our Part A reimbursement and changes to that model that we lovingly call patient-driven payment model. In my role as Chief Product Officer, I too am tasked with keeping up with what's happening in the post-acute care, not only for reimbursement, but for regulatory, for quality. We had a new technical manual come out this week for 5-star, and I do that so that the solutions that we offer on our platform are in line with the needs of the post-acute community. Today, together, we're going to share knowledge, we're going to share thoughts and strategies for success. And together, we're all going to become one step closer to PDPM experts. Next slide. So I'd like to highlight 5 key changes that I see in the PDPM model. First are the payment drivers themselves. Could you go back a slide? Thank you. So the payment drivers are predominantly resident conditions and comorbidities of the patient. It considers function, it considers condition, and while RUGS-4 certainly used patient data, the index maximizing rules allowed provided therapy to drive those reimbursement dollars. That actually speaks to the second change I like to note, which is that under PDPM, payment drivers move away from the therapy that's given. Providers, of course, are still going to be required to track, record, monitor those therapy minutes. We'll have to look at it by mode of delivery, but it's no longer data that's going to actually drive your group assignment. The third key change is a welcomed reduction in MDS assessment volume. And while it's probably a relief to your MDS staff, I don't recommend a reduction in FTEs prior to the transition in October. With just one assessment, the need for accurate data capture is actually heightened. And that's going to bring me to that fourth change. 3 of the case mix indices are actually variable rates. They're going to change over the course of the inpatient stay. That's going to make changes to your daily payment based upon your length of stay. And the last key change, which again is foundational to our discussion today, is that the daily rate is actually made up of additive rates from 6 distinct components. It's actually the piece of PDPM that I like the most because there's different data elements that are driving each of those groups. Next slide. So to be successful in any data-driven model, you must design systems which get your team the data that they need. It has to be accurate and it has to be in your hands. How will you do that under PDPM? Well, I think a lot of that starts with the referral process. Your hospital partners bill using DRGs, but they communicate with us as SNF partners using diagnosis and problem lists. Your admission team members must capture both, and they have to capture both for longer periods of time than they do today. Those diagnoses, those problem lists are going to be used to predict a daily revenue range. That daily revenue range allows your team to really think about and evaluate the needs of that patient, to estimate some cost to provide that care, and to think about the fiscal viability of admissions. I think success under PDPM is really going to depend on having those tools which will support this predictive revenue and cost process. And of course, with that data, that pre-admission data, you're from a regulatory perspective, you're required to produce a resident-centric care plan designed to achieve optimal clinical, functional, emotional, psychosocial outcomes. That's not going to change for any of us under a new payment model. I do think what will change is that you'll be measured by the efficiency of some of the functional changes you can accomplish over time. I think that a new KPI we might be talking about will be some of these efficiency type of measurements specific to function. The next data element you'll need will be the ability to predict those daily reimbursement dollars. Again, you're going to have to aggregate them for your facility, track them compared to your RUG dollars, and monitor those metrics during the current transition in order to get an assessment of how revenue will be impacted. This is actually something that we've been doing at Prime Care Technologies for our business intelligence dashboard clients. It's my goal to give our operators the visibility they need into the dollars that as the change occurs coming up in October. And our thought as a vendor partner is that we need to provide the tools to allow providers the ability to ensure consistency between the data that's in your electronic medical record, your MDS assessments, and your billing data. On our platform, we actually work with all those types of data, which to me is a great privilege, but I know with that great privilege comes responsibility. And that responsibility means I've been putting a lot of time into PDPM measurement and analytics, and those things have made their way into our solution platforms. The last piece you're going to need, in my opinion, is some interim payment assessment, some IPA decision support. Basically a preview of the ability to think about what it would mean financially should you choose to do another assessment. Next slide, please. So we've talked about some strategies for making PDPM work for you, and I talked about getting it right on that admission MDS assessment. For a big part of my career, I focused on MDS accuracy, and that's not going away for any of us. Yes, there will be less volume of assessments, but the comments I made about the importance of capture of information from the hospital, it's going to take additional time. So keep in mind, there's different parts of the MDS that are now going into 6 distinct case mix groups. And so again, it's the part of PDPM that I really like. We finally will have what we've been asking for in some non-therapy ancillary consideration, some nursing consideration on top of skilled therapies consideration. But any inaccuracy in MDS items that are going to drive those other case mix groups can ultimately hurt your PDPM overall daily rate. Next slide. I wanted to share with you the #1 question that I receive when I'm teaching on PDPM or talking with customers, and that question is, how much therapy should we provide? And my answer is really going to come from both a quality and a compliance perspective. In general, you're going to be providing the same amounts of therapy under PDPM as you did under a RUGS system. The difference is that your interdisciplinary team will have to talk and discuss and really come up with a plan of care. Those discussions will include the frequency, the duration, the mode of their skilled therapy in light of all of the other skilled nursing issues which work together to impact someone's tolerance, their outcomes, their ADL improvement. This is really, to be honest, how care is being delivered and has been delivered for many, many years in the post-acute space. I believe that our therapists will naturally come back into planning conversations, and my suggestion to you is to really bring together your director of nurses, your director of rehab, and your administrator, and really discuss their knowledge, their functional knowledge base of things like care mapping, projected length of stay for major diagnostic categories of patient care. It's really not so much a mystery to our physical therapy partners. They're well schooled in this kind of knowledge. We've finally given them in PDPM a more of an open canvas on where they can provide their clinical expectations of patients in the care planning process. Remember, from that compliance perspective, what you present to CMS as reasonable and necessary care right now, today, really should not change in October. So if you look at the intensity of services you're providing for a diagnostic type of patient today, and you're convincing CMS it's reasonable and necessary, I would expect that to look the same in October. Any notably different changes in your data will put your compliance in question. Next slide. So I use the 5 key areas to outline my comments here for you today. I'll just recap really quickly. First, invest in some ICD coding training for staff. Not certification, not over the moon, but some decent training for staff. And give them tools that vendors provide on ICD-10 accuracy. Ask for more detailed information from your hospital referral partners and give time to your staff. It's going to take some time for them to add a diagnosis to your chart. It's going to require communication with physician partners and confirming your primary readmission reason to your SNF. Remember, your therapy data is still going to be collected and analyzed, and it's going to be looked at to see how quickly you can reach those functional outcome metrics, along with your discharge to community quality measure, your length of stay metrics, and your rehospitalization rates. So give your world-class staff the tools that they need to accurately predict in PDPM CMIs, and give them the help that will help them when some of those item responses don't really look quite right. I'd also say don't forget about your business office managers, because variable rates that are changing over time with length of stay, it'll require attention as a part of your triple check process. They may need some additional education around that piece. And lastly, remember, there are 6 case mix index pieces to PDPM. So your focus needs to go beyond ICD-10 and actually get to those other items that are driving those CMIs. I think PDPM represents a unique challenge with many possible combinations, and manually checking is really impossible. And as I wrap up, I just want to empower each of you to be an advocate in post-acute care community. Take the time to engage with vendor partners like us at Prime Care Technologies. Ask about their solutions, what feature sets are being designed with your PDPM success in mind. We are all, of course, reminding ourselves and learning as we move away from a rug-based model and becoming more expert in PDPM. And now I'll pass it back to Clint.
Thanks, Cheryl. That was great information, right to the point, things that you have to think about every day. And many of you are already starting in those directions. But again, that's great strategy. Next, we got Joe Tomeno, who's the Chief Executive Officer for Grassi Healthcare Advisors. And Joe has been a professional in this industry industry's a terrible term for this commitment, this dedication, for years and years and years. And Joe's going to give you some opportunity sides for the categories. So Joe, take it away.
Thanks very much, Clint, and it's a pleasure to be part of the panel today. Patient-driven payment model, wow, what a tongue twister, PDPM, is probably the biggest change in Part A reimbursement since PPS first started. And it really fundamentally changes the paradigm from us categorizing patients based on the amount of care we provide to what they actually are presenting by way of diagnoses, by way of function, by way of other factors that we assess. As Cheryl said, it's going to be critical that not only the ICD-10 coding is accurate, but that each of those 6 components gets accurately categorized through the MDS. So back when PPS first started, I was a director of nursing in a large facility, and the industry joke was that everybody was putting tents in the parking lots of their nursing homes because you wanted to start people on rehab before they even got in the door, to start generating those minutes so that you could get the categorization in the higher rehab categories. Of course, that's an exaggeration, but it isn't quite far from the truth that we really fundamentally changed how we delivered care in facilities to be able to very aggressively upfront get care delivered at a very high level in order to be able to capture it on that initial MDS. That pressure is relieved somewhat with this process, where it's really based more on a kind of a rational assessment of what the patient needs and what the care needs of that type of patient are going to be. So it brings with it both opportunities and challenges, and we're going to touch on those through this presentation. Next slide, please. So in summary, your facility, as I said, will be paid for what your patients need, not for what you deliver. Now, that means that you still have to deliver the service. You can't just measure what they need and get paid for that and not deliver the service. That would be a False Claims Act violation, and you'd be in severe trouble. But the whole focus of categorizing the patients is fundamentally based on that assessment. You must deliver the care your patients need, and as was mentioned by Cheryl, you can't really fundamentally change how you deliver care. Although I think the kind of the innate bias of the system to drive, say, for higher levels of minutes to generate more higher rehab categories was built into the system, and I think CMS has been trying through changing the model to get away from incentivizing that and looking more at what's the rational, appropriate level of rehab that a patient needs based on their diagnoses and their functional level. The sicker patients are, the greater the opportunities are for payment. And I think that some wonderful things have been done with respect to the non-therapy ancillaries and the comorbidities that are captured through the MDS process. There's increases in points for AIDS, for organ transplants, for leukemia, for multiple sclerosis, for wound infections, for patients with diabetes. And capturing this data will be critical to make sure that you get appropriately reimbursed. Patients with lower levels of functioning are no longer paid more for rehab. The system was based on that people that had more functional ability and were able to participate more could generate more minutes, and they got more compensation for rehab. So the new paradigm is the inverse. And CMS has incorporated more reimbursement for IV medications and other advanced care that sometimes we felt were under reimbursed in the RUGS model. So this is another opportunity. Next slide, please. So the question I'm getting all the time is people are saying, what's the new Rehab Ultra? I think under RUGS, people strive to get as many ultras as they could because that generated the most revenue and presumably generated the most profit for the facility. For years, myself and some of my other colleagues in the industry have been saying that ultras are not necessarily the most profitable. Yes, they generate the most revenue, but they also generate a tremendous amount of expense to achieve them. And it's actually been some of the mid-level rehab categories that are more profitable in terms of generating a margin. But anyway, be it as it may, the ideal patient is no longer kind of able to be identified in a singular fashion. The complexity of the model, looking at 6 different categories and all the additional points you get for the non-therapy ancillaries, there is going to be no one golden type of patient. I think the answer is that you're going to want to search out for medically complex patients who need rehab to restore their function and get back to wellness, and in addition to the skilled care that they might need. And the optimal ones are those with comorbidities and care needs that get captured in that non-therapy ancillary group. So as Cheryl said, having access to data in that pre-admission phase and understanding those drivers of higher reimbursement are going to be critical, and it's not going to be so easy to just simply identify a singular type of patient as we were able to do under RUGS 4. Next slide, please. So what do we do now in this environment? What patients do we kind of strategize to go after? I think, and it really isn't just because of PDPM. I think we've already seen in the industry, probably through bundled payment initiative that went on with hospitals and other managed care initiatives, that we're getting fewer and fewer of the kind of traditional knees and hips. It's no secret that for years now those have been diminishing. Kind of sadly, there hasn't been any big outcry by the consumer that they wanted nursing home care. And I guess the outcomes have been not challenged, so it really didn't matter that they weren't going to nursing homes. So that I guess could be disputed. But anyway, it's a reality that we're seeing fewer and fewer of those. So what do we go after now? I think what's important to do here is to really understand the needs of your referral sources. Look at what their challenges are in terms of complex patients, their post-acute challenges, patients who are overstaying their length of stay from a DRG perspective, patients who are being readmitted. When I say patients, I mean categories of patients. So, you know, they present for you opportunities to align yourself with your referral sources. So, for instance, if you have a referral source who has a real problem with congestive heart failure and they have a high readmission rate, they have trouble getting them home and successfully at home without coming back in, it gives you the opportunity to really develop a sophisticated program, clinically integrated with the hospital, to provide the top level of care that can achieve success, get the outcomes you need. So based on evidence-based care paths, refine your care practices so that you have few variations in care, you have no complications, you don't send people back to the hospital unless it's really appropriate, and plan for the shortest effective length of stay. Next slide, please. In order to accomplish this, you really need to have the right staff. You have to have the team that is all prepared for those populations that you've identified, that have the skills to care for them, to make the assessments, to provide the care. You want to make sure they're all working to their top of license and as sufficiently as possible. You also want to assess your facility. Are you equipped for caring for those types of patients? For example, if the category you identify as in need is COPD, do you have built-in gases in your walls, provide oxygen through the walls, or do you have to use the old concentrator model? So this might be the opportunity to do some investments in your technology to prepare yourself and make sure that your facility is really up to where it needs to be. And of course, you know, train your staff. The only thing worse than not going after these new populations would be to go after those populations and not have your staff, you know, prepared for them. Next slide, please. So develop your new admission target profiles based on what your understanding of the types of categories you want to get, and this kind of community assessment that you do, and development of specialized programs. Train your staff in the ICD-10 coding and the new MDS data elements. Make sure you get those functional and cognitive assessments and your speech and language assessments done as accurately as possible to make sure you're capturing all your revenue you have due to you. Next slide, please. For your rehab line of business, you want to redefine your measures of success. And you want it based on care based on need, not reimbursement. You want to assess the right level of rehab staffing and plan for the appropriate use of concurrent therapy, not more than 25%. And you want to renegotiate your contracts with your therapy vendors to reflect these new realities. So in summary, I think, as I said, there's both opportunities and challenges with new PDPM payment model. And I think, as Cheryl mentioned, I think it's exciting that we're getting credit for a lot of categories that I think were under reimbursed in the past. And I think there's perhaps a more rational approach to kind of the rehab level of effort that goes into getting the outcomes we need to get. Clint?
Thanks, Joe. Appreciate it very much. You gave us some great ideas on the medically complex folks that we should look at, the type of business model that we want to go for. We're going to take that a little farther and keep stacking on top of this. Our next presenter is Chris Mastrangelo, President and CEO, Harmony Healthcare. Chris is a known knowledge broker in this particular profession and does many areas of work along reimbursement, and in this particular deep dive new patient-driven payment model. So Chris, thanks for joining us.
Thanks for having me. It's great to be here. And just to continue on the conversation on the, sorry, I'm just getting my slides set up. Can you see my slides yet? Very good, those are them, great. Okay, so we have the intro and we talked about sort of the concept of PDPM and the shifting from resources to clinical acuity, and obviously, you know, the systems review. And I think that to give you a, you know, my 12-minute overview of strategies and market position, these bullets best define areas to focus in on. And to echo the, you know, the prior two speakers, you know, Joe and Cheryl, you know, clinical capacity is really important. Understand that PDPM in my world highlights the nursing care. The 5 components that are used to calculate the rate, what it's doing is saying, hey, listen, your RUGS system still exists. It's highlighting it in this system. And what needs to occur is that the MDS accuracy, of course, is always and will always be super important, but what can you do further than you're already rendering? And when you define that, how does that fit in the market? And then obviously to ensure that you have competencies for all of your staff to render said services. So sometimes it's sitting back and really reflecting when you do your facility assessment, what is it that we actually do? Because many, many operators across the country underestimate the complexity of what they're doing. We all know that 9 out of 10 patients in the United States fall into a rehab RUG category. That overshadows the nursing component. In fact, nursing is providing services. It's just that with a resource-driven model, if you have therapy and nursing, the case mix index will naturally be higher. This new system, again, highlights the nursing resources and delivery. So you're looking at your clinical capacity. Do you need training? Do you have a market that can refer more patients, or are you already doing it? Looking at your competencies and who needs to be trained, who can have ongoing training and to perfect it and to become relevant in that market. Systems has been the theme for the long-term care industry for the last 3 years. Systems refinement is a product of the requirements of participation, which is a fundamental Dr. Deming principle of QAPI. Let me say that a different way. When the surveyors come in, they're going to look at your systems. So you don't think of this as, is this a systemic issue? Think of this as, I had one issue, why did it go wrong? And what system do I have in place to prevent it from happening again? And we talk about this a lot on the QAPI trainings, but in other words, it's separation of responsibilities and ensuring that multiple people have their hands in the task. As I talk about, you go to the drive-through for the Chick-fil-A, and you're in Chick-fil-A and you go to the first window and you pay. The second window, no, the first window you order. The second window you pay, and the third window you get your food. Why? Systems, because it's an internal control. If one person sat at the window and took the money and the food, there could be theft, slippage. This system of 3 different spots affords Chick-fil-A to scale and have internal controls on slippage of money, fraud, and theft. So looking at your own healthcare systems, what do you have for triple check? Well, most of you primarily have triple check for billing. You need to look at it for other areas in order to be in a good market position for this. Care planning. Care planning, again, I will tell you, in 1998, I lived through going from a cost-based reimbursement to a prospective payment system. It was what I call care colliding with reimbursement, right? Prior to 1998, we used our clinical judgment, and by the way, we probably gave 12 to 1,500 minutes of therapy, okay? This is what we did. We used our clinical judgment, right? All of a sudden, bam, a collision between how they're paid and what we render for services. What's happening now? We're in a tsunami of care, reimbursement, and regulatory and survey, because you've got value-based purchasing, QRPs, everything's coming at you. Care planning is the foundation for everything. Remember that MDS originated by OBRA 87. So you talk about 20 years ago is when we had PPS, 30 years ago is when we had the last massive regulatory change. So care planning is a product of OBRA 87 and ensuring that you are providing those patients with individualized services. PDPM connects the dots because it's patient-driven, care planning, patient-centered, so therefore everything's tying in. Be very, very mindful of how you're care planning and if you have the resources and competencies and systems and clinical capacity to do so. Dollar impact. So again, we know that we have to be able to count in order to have a viable business. So what's exciting is that, you know, there's models out there, but Harmony is super excited because we're going to launch our app next week on being able to put in the five components and know what your rate is by day for the whole 100 days. That's where finance and clinical have to lock arms. What services are you rendering? And can you render them appropriately? And it all aligns with the care planning, the competencies, and your capacity. But again, with this, the dollar impact of this model is quite intriguing because a patient could be with you for 2 days and you could essentially get up to the $1,500 a day. It's incentivizing you to have a shorter length of stay, but be mindful and cautious. Back in 1998, they also incentivized you to not give therapy because the SE3 paid greater than an RHC. Do not let the tail wag the dog. Provide the care that is needed. Also be mindful of the fact that while the rate may be higher with a shorter length of stay, you are also faced with hospital readmission percentage take back and return to community. So 30 days after they leave your facility, if they go back to the hospital, you will also have that in your QRP and value-based purchasing model. So understanding the financial impact is super important, okay? Back to MDS coding, Cheryl talked about accuracy. The MDS is the foundation for everything. Yes, hooray. There are far less assessments to be completed. Great, CMS heard the industry, okay? But remember, this MDS is 1,000 points of information and it's dynamic. And every MDS coordinator I meet with across the country, they have the same exact personality. Those of you that are on the call, you know you, right? We're organized, OCD, checklist manifesto, right? Great, we're gonna keep doing that, right? Keep doing that accuracy, but understand that the irony is that the MDS coordinators are perfectionists, but that tool is still so complicated that be fluid, be dynamic, and know that it's gonna change. Meaning there's gonna be errors, but you have to minimize and mitigate as many errors as you can by virtue of the fact that there are less assessments. Staffing. Okay, so staffing comes into play here, right? You've got your 5-star. You've got your requirements, transparency. Everyone knows what you're doing, right? So is your staffing aligned with your acuity? What does that go back to? Your MDS, right? If your MDS is undercoded, your staffing may look as though it's over. If you're undercoded, exactly. If your MDS is hypercoded, you may look understaffed. Be mindful of the connection there and looking at where you stand in relation to your competitors. Of course, PDM brings a whole new level to this. Right now, you're accustomed to the MDS driving payment. Well, now you've got ICD-10s, you have the documentation in the medical record, and by the way, you do not need to give a minute of therapy in order to have the therapy component. Sit back and breathe and think of that one for a minute. I'm not advising at all for you not to give therapy. I'm a huge advocate of therapy in the skilled nursing facilities. So, but realize that your rates will be determined on the coding, the configuration of the 5 components. There are 281,000, let me say that again, 281,000 configurations of the PDPM. It's mind-blowing. So your documentation has to be reflected in order to capture it and have the accurate component reflected for your rate. And then we go to quality measures. My all-time favorite, 3 August ago, I sat in the room and I had all the team in there and I said, how many quality measures are there? Well, there were 43 3 years ago. There's probably 53 now. And hospital readmissions there's 3 of them, one for QRP, one for value-based purchasing, and one for 5-star. It's complicated. Breathe. I always say go back to simplicity, right? Fill your beds, collect your money, give good care. So those quality measures are here. They're here to stay. They are metrics that you want to use. You want to use them and compare them as you're delving into PDPM and preparing for it, but they're always going to be around and they're always going to be measured to compare and contrast you to all the other 14,000 nursing facilities across the country. And of course, your pre-admission data. We've said this multiple times, but of getting that data, because realize when you're coding the ICD-10, therapists that are on the call, you're coding for the services that are rendered in the SNF, not the diagnosis in the hospital. So you have to be mindful of that. You are accustomed to that, but there are 2 different elements here. Okay, why were they admitted to the hospital? And then what is the reason that they're receiving skilled nursing services, skilled therapy services? And the premises, the pillars of skilled services coverage criteria do not go away. What we saw in 1998 was a drastic decline in the number of Medicare Part A patients because there was massive confusion on what constituted skilled services. So I'm cautioning you, do not fall into that same path of getting mixed up and not having, it's all about your census. So understanding who is skilled, what is skilled, and how you're going to navigate through that. Again, look at the history to know what's going to happen again. The other piece, and I think I'm going to go to the next slide, if it goes to the next slide. And next slide, please. Thank you so much. 2 comments. Looking at your vendors and your vendor relations, because of course, it's a whole different playing field here right now. You have to say, okay, my relationship with my vendors is going to change by virtue of the fact that my reimbursement is going to change. So if you're paying by the minute, you may not be paying by the minute anymore because the minutes do not correlate. You might be paying, some other structure. So you have to have your vendor relations, on the docket for review and have alignment and simpatico in that sense. And I think at the end of the day, one of the things that we're telling our clients is that just breathe, because don't be reactive. What happens in October of 2019 may be greatly different in October of 2021, because the system will have to be refined because we don't know what we don't know, and there might be flaws. So be very mindful of how you have your service delivery. And again, our big premise is medical record review, because that's the devil's in the detail, always having under the mandated compliance ruling, always having someone coming in, doing these audits and monitoring to find the areas that you can improve upon. And that's the end of my section, and I'll pass it on to Sharon or Clint. Thank you so much.
Well, thanks, Chris, very much. Great strategy, bullet by bullet points for people to pick up on that leverage also what Joe and Cheryl had previously said. Now we're going to take a look at your financial opportunities and financing for success. And one of our sponsors of this particular webinar is Love Funding. And Sharon Tholes, a director of origination with Love Funding, and has had a past experience in operations herself too. So Sharon, I'll let you take it over.
Thanks, Clint. I appreciate being here today. One of the things that I really wanted to focus on, and really my slides are very cut and dry, and they're really focused on the executive level people on the phone. As the nurses and nursing assistants and those people are preparing for PDM and working very hard to sort through all of the information that our experts have given us today and setting up the systems in the facility for success, as executives of your building and being responsible CFOs and executives, looking at your balance sheet is also important. And looking at, you know, your mortgages and your lease payments, and those things are very high expenses that you have to cover through this uncertainty of PDPM. And guaranteed everybody's going to figure it out and everybody's going to get in stride, but to proactively think about how your facility is financed, and are there opportunities for a refinance to position you better in this kind of uncertainty of a time regarding the revenue that will be coming into the facility. Love Funding focuses on HUD financing. Of course, it's a long-term fixed rate debt, and it's probably the best situation for skilled facilities in kind of uncertain times. You have a set mortgage every month, and it allows you to know what you need to back into from a revenue standpoint. Next slide. Also, if you were to refinance, you know, it allows for freeing up of cash. So as you're looking at what needs to happen, those nurses need help with training. They need resources. They need that extra cash right now to help get them to the point that they can be successful under the new payment system. Also, as we've talked, those buildings that are going to maintain market competitiveness, they have to have the equipment. They have to be updated and, you know, present well to the customer, as well as developing specialized programming. All of those things take an exorbitant amount of cash. So to remain market, you know, to remain market competitive, you really need to be thinking about that, CFOs and executives on the phone, about how can I help these nurses and MDS and clinical teams get to the point that they have all the resources they need to be successful in this new environment. Also, I know that Clint is going to talk about this, but you know, investing in the strong marketing teams to get into the hospitals, to be able to showcase the services of your new programs, of the clinical capabilities that you have. You may, as you develop programs, have to solidify another medical director, because the level of care is so high in your facility that that you need to have those solid relationships to help you get those solid outcomes and help you with your 5-star. So really, the point of, you know, my presentation here today is for not only is this geared towards, you know, the RNs, LPNs, directors of nursing, administrators, all of those people that are gearing up for it, but CFOs and executives on the phone, you really need to look at how you've positioned your debt and where you're at, and are you in a good position on your balance sheet to be able to fend through some of this uncertain time with PDPM. That's all I have. Clint?
Thanks, Sharon. I think that stability financially is a big deal, and I agree exactly with what you're saying. However you decide to make your financial decisions, knowing what your debt is, knowing what you're going to pay, knowing that you don't have, you know, big time escalations and changes in the payment structure is a giant thing as you move forward to take your money and plow it back into these kinds of areas that we've been talking about. Next presenter I'll introduce is me, so I'll just introduce me, and I'm me, Clint Mound, and I want to talk to you about how to market, or PDPM, and your revenue. So if we take the first slide here, and I just kind of walk you through a step-by-step of what we do all day, every day, you have to make a decision with all that's been said here that you're going to advance your clinical capability attitude, and that starts internally. You have to decide that if you want to move in the direction PDPM is asking you to move, to take care of the patient-driven needs, and you want those patients that you want and that your partners want you to take, it is an advancement of your clinical capability. If you want to cherry pick and have a list a mile long of people you don't take, PDPM may or may not work out for you. You know, PDPM comes out to be the federal government's determination is it might be an interim payment process itself that moves in the Impact Act to other coordinated care reimbursement models moving forward, and it sticks in there somehow, yet again remorphs. But the feds have made it clear that there's only so much money in Medicare, and they're not going to let this thing turn into more money. if you will, out there. It's just a shifting of the money. But it doesn't have anything to do with you getting your unfair piece of that revenue. I want to say that again, your unfair piece of that revenue. Look, at the end of the day, you're competing not with the federal government or with the regulatory systems or the press. You're competing against your competitors down the street. I mean, the government has pretty much set it up through their insurance partners and the regulators and their own reimbursement system that, you know, if Joe Tamano and I are out in the woods and the bear's chasing us, I don't have to beat the bear, I got to beat Joe. So I'm going to have to tie his shoes together or, you know, point out a big sandwich for him to eat that lets him be a little slower than me, so the bear will get him. So you're competing against everybody else out there. So the first step is you have to decide to have an attitude about clinical capability, and it needs to be a positive one, and that includes all the people that have opinions about what we can do, what we can take. I mean, Sharon said, hey, maybe we have to advance our key staffing, and Joe said maybe we have to put equipment in, and Cheryl and Chris said maybe we have to advance the way we think about how we collect our data and use our information. So that might mean that we'll need a team-based approach to this, including with our therapy partners. But at the end of the day, if you want to go after what PDPM is going to offer you to get an unfair advantage, it starts with your own attitude. So your clinical advancement is on your referral source needs. I would not go out and invent a bunch of things that we're going to do better, taking certain types of people without making sure it met my hospital or managed care or referral source needs. You have to organize it internally first before you go external. There's no use going out with marketers promising to the hospital systems that we're going to take all these sick people. You know, we use a model called QST. You have to take them quicker, you have to take them sicker, you have to watch the ticker. Quicker, sicker, watch the ticker. The ticker is either how long they stay under bundles or managed care or hospital partnerships, or that they don't go back into the higher level care, that's rehospitalization or readmission. So quicker, sicker, watch the ticker, but you've got to organize that internally first. You can't be running around out there promising people will take all these folks and your entire internal team goes, God, we've got no nurses, we haven't trained up, we don't have any equipment, we don't have great suppliers, you know, we don't even have a great attitude about wanting to take all these people. So you got to organize it internal first, then you go after your referral source meetings, target your model, your marketing, and plan your follow-up. So as we go through this, the next slide, please, Lauren, you would want to design your internal plan. That would be discuss the referral source needs. I mean, there's ways to get that data from federal and government and brokerage websites that can give you the data. You can go in and ask the hospital for the data. I think it's a perfect opportunity to go in and ask the hospital for data right now, since you need the data for their problem list and their DRGs to be able to do your ICD-10 coding and your MDSs accurately and to set up your payment, your reimbursement plan. So why not go discuss what they want you to take? What are their issues, their opportunities? What kind of stuff are they worried about? Joe said earlier, if they have a lot of rehospitalizations on readmissions or readmissions on congestive heart failure, maybe you need to be the player over anybody else in the area that can do congestive heart failure as a disease line better than anybody. So you have to discuss their needs, not just what we think it would be cool to train up. You got to get team buy-in internally. That's where you executives have to go to those meetings with your local base centers and say, are we going to get buy-in on this or not? You can't have a couple people sitting around griping or complaining, or what we call BMGing, belly aching, moaning, and groaning about, you know, we don't want to take these people and we don't want to take these sick people, and, you know, we'll have all this trouble if we do this. You got to develop the training before you, and your plan for training. You got to get your vendor support. That's not just your contract therapy, but that's your infusion therapy, your respiratory therapy partner or on-call partner, your physician relationship partners, your DME partners, it's clear on out to, might as well get all your follow-up partners you need too in home care after they transition from you. So you got to get the vendor support. I just said the physician support is huge. I mean, you can't be all excited about taking sicker people, and we've got a disease specialty product line, and the hospital wants us to take it, and your physicians aren't on board with that. In fact, you know, they're not very interested in getting calls from you or supportive conversations, or anytime they get real sick, they just send them back to the hospital. I mean, that destroys the entire plan. And then you've got to build excitement. We're big about teams and team-based excitement. And before I would ever go out into the marketplace to market what we can do, I would get excited people that would say to the executives of your company or the marketers or the business development people, please go get us some business. We want it, we want it, we want it, versus, oh my gosh, I hope they don't have any success. So you got to build excitement. The next slide, please. You would want to have a referral source meetings that you have to prepare your assumptions. I like to walk in with, we think there are 3 areas from some data that we've looked at on who you're not getting out of the hospital, who might be staying too long in the hospital, who's causing you some financial problems in the hospital. Now, we may or may not be right, but here's 3 or 4 areas, and we just thought we'd start with, golly gee, here's some assumptions about what you need. In other words, you do not go in talking about you. They don't care about you. You go in talking about them. It's like if your neighbors said, would you like to come over to our house and see our once-in-a-lifetime pictures of our trip to Hawaii? No, not really. I'm living with this idiot, and we haven't been out of the county in 5 years. No one cares about your story or your pictures. They want to talk about what they need. You got to secure the correct people for the meeting. Yes, that could be discharge planners and head of post-acute care collaboratives, and yes, it could be hospitalists, but I do like people with C titles in front of them, you know, CMO, CFO, COO. Yes, the CEO of a hospital is good, but the CEO of a hospital may or may not be as interested as some of those other people who have skin in the game. You got to talk about your needs. I mentioned that. You got to work to get specialist involvement. How could you do that? Hey, if we would start a product line on, I'm making up something, you seem to have a problem with sepsis. If we would borrow some of your specialists to help us write the care paths, the critical pathways, the protocols, we would pay you for their involvement, and we would like to help you do something cool with that sepsis problem you have, and we would become a specialist. Now, again, I'm not telling you that you should become sepsis specialist. I'm just saying that's an example, and we've had clients do that. But then the great news about the docs tend to say to their patients, well, you're going to need post-acute follow-up. Well, what should I do? Well, you do what you'd like, but I help write the protocols and the clinical pathways for XYZ healthcare, which is yours. You have to discuss the money and the service upside. You got to be not afraid to discuss money, including if they're going to chip in and pay for something in a narrow niche partnership, and what would be the upside for them in money. You have to discuss that there might be other partnerships you'd like to. Would you like to talk to us about our lab, our x-ray business, our transportation business, buying physician services from you, buying training from you? There's a money conversation beyond just the niche you're trying to target. Then you have to set the follow-up for that too. So the last slide would be that you have to set up coordinated and continued work. So you got to, so let's say you get your first case of a certain type of DRG or problem list from them, and we're going to, I didn't say we take 12 of them overnight. We're going to try our first one, and we prepare for that first case. We're trained up, we're ready, we're excited, and we're going to knock it out of the park. Then you develop that targeted marketing plan of how we're going to go back and showcase what we did, the results. You want to document all the training and the specialist work that you did so that you can use that back in your conversations. You want to prepare great outcome documents. That's one of the purposes with vendor support, to help you get outcome results. That's the purpose of your great in-house or external contract therapy partners, to get you outcome results along with the clinical results to show that we're doing it. Winner, winner, chicken dinner. So then you have to plan for the next follow-up resource meetings, referral source meetings, and then that sets you up to be ready for the potential to do niche marketing. And again, quicker, sicker, watch the ticker. If in the sicker category you have 3 or 4 niches that allow you to get a real movement on a certain product line that's tied to your analysis of PDPM reimbursement, you have a chance to showcase that going forward. So that's how I would set it up. It's internal first, then it goes external, then it goes back to what we need to do internal to take it back external again, the yin and the yang. Thank you. And now our conversation turns to a great person, Susie Mix, who's the CEO and president of Mixsolutions. And Susie is going to talk to us about that age-old opportunity that's arising out there and what's going to go on in the world going forward about managed care. Susie, you're up.
Okay, hello everybody. Happy to be the caboose of this webinar. Difficult to always follow Clint, but happy to go over a couple slides with you. I'm going to keep it short and sweet. Usually that's not the case with managed care. Usually it's our biggest pain point. But what Mixsolutions does just in the industry, in the post-acute industry, emphasizes in the post-acute industry is managed care. So anything managed care we're usually involved in, whether it be contracts or case management and so forth. So Lauren, if you can click the slide, please. Again, short and sweet, I only have 2 slides. I'm happy to say that managed care is not going to be your biggest pain point for PDPM at this time. There's a lot of things that we need to prep for, a lot of therapy. You guys listen to some great speakers who have given you some strategy to think about. But when it comes down to managed care, there are just a few tips I want to give you, a few things I want to have you guys think about as we enter into October 1st of this year. First and foremost, I would definitely suggest at this time to take a look at your managed care contracts. Hopefully you guys can find those contracts and have them handy. You're going to want to take a look particularly at the contracts that are RUG-based. So if you are getting reimbursed with a managed care contract with RUG-based contracts, so 90% of RUGs, 100% of RUGs, whatever the percentage is, you're going to want to take a very close look at the verbiage being used. If it does state that there is a RUG-based reimbursement, RUG, RUG-based, that is a conversation you're going to have with the health plans. You're going to have to call them up and let them know. Hopefully they do know that come October 1, we are going to be changing that up a bit. And just see if you do need an amendment for that contract. You definitely don't want to do it in October. You don't want to do it the month before. You want to start that conversation right now. For those of you folks who look at your contract and it says that you're getting paid 100% of the Medicare fee schedule or 100% of Medicare, you are still safe. That is, come October 1, they will just switch you over to paying you PDPM. So it is not a contract that you would need to amend. It's just a contract that's going to say come October 1, these health plans are now going to pay you the PDPM rates. With that being said, that's great. That's nice that we don't have to have an amendment for that contract. But keep in mind, as we are learning about PDPM, so are the health plans. And I don't believe that the health plans and the ones that I've spoken to throughout the nation are putting as much effort into figuring out PDPM as we are, as obviously that's the crux of our business, the reimbursement, the cash flow, the bloodline of our business. We're putting a lot of effort into figuring out PDPM and how it works. Health plans, not so much. Most of them are aware of PDPM, but they're not exactly sure of what's going on with PDPM. So when you're having that conversation, you may need to educate them. Most importantly, we don't want to be caught on October 1 or right before then with a RUG-based contract without having a conversation with the health plan. Next slide. This is just a food for thought actual slide. In talking to Clint about doing this webinar, we are all struggling to make sure we understand PDPM, and truly we can do as much proactive work as possible, but we all know that once it comes about is when we're going to really understand it, know it, make sure that we're on the right track. So I've had a lot of clients come to me and say, Susie, let's figure something out with the health plans right now. Let's go to them and say, look, I want to set this type of contract up, that type of contract up. PDPM is coming. Let's just let's have the health plans. We don't like levels. We don't like, they just pay us a lot less reimbursement. We have to be careful how we strategize. Unless you're 100% certain how PDPM is going to affect you, your business, your facility, it may not be the wisest move to walk up to the health plan and demand that or request that. So my food for thought in running a skilled nursing facility and trying to get everything together for PDPM is absolutely do that. Get all of your ducks in a row and think about how, as it's affecting us, Is it a positive? How is that affecting us? And if it is a positive, then our conversations with our health plans will be geared more towards trying to get reimbursement that is PDPM. If it's not working for facilities and there are other strategies or other thoughts that you have about risk that may be more appropriate, then you're going to want to have those conversations with the health plans. But my thought at this point and what I want to share with you is that don't jump in just right now and demand from these health plans. A lot of them don't even know how to adjudicate a claim through PDPM. This is all new to them. So does their claim systems even read PDPM? Do they even know how to put that in their system? So we don't want to be quick to push the PDPM down their throat if they're not going to be able to pay us properly. I said I was going to keep it short and sweet. That is all I have. Clint, I'm going to kick it back to you.
Thanks a lot, Susie. You know, I think the big news there is that getting on top of it now on the RUGS system before October 1st is extremely important. So the last thing we'll do here quickly is just any final thoughts from our panelists. I guess I would go, Cheryl, back to you first. Do you have any final thoughts for anybody?
I just want to thank the other speakers. As I said in my opening comments, you know, we are all learning PDPM together, and I think that what we heard here today was really, really excellent. It was a terrific session. So thank you.
Hey, Joe, you got anything?
Likewise, I think this has been very informative. I think the bottom line is good patient care makes good business practice. And I think Chris, punctuated that, and I think we can't lose sight of that. And if we focus on good patient care and refine it with the data and keep it in alignment with payment, we'll do fine.
Okay, Chris, you got something? Final thought? Oh, Chris.
Me now? Can you hear me now?
I can hear you now.
Okay, sorry. I don't have much else to say other than I'm grateful to be on the panel. Thanks for including me, and I'm glad we could share this with the industry, and it's been an honor. Thank you.
Thanks. Sharon, you got anything financially for people?
Just that, you know, we're solution-oriented people, all of us on the phone here, and we put this on and sponsored it so that everybody, you know, is looking at all aspects of their business. Like I said, looking at the balance sheet as well as the income statement on how they're gonna, you know, approach this kind of uncertainty. And, you know, any questions for us, again, I think Lauren touched on that at the beginning. Please email us or message us through the webinar, and we're happy to get back to you on any questions you might have. Thanks, everyone.
You know,
yeah, and go ahead, Joe.
Yeah, I think, you know, we have a few minutes left on the webinar. We could read a few of the questions that have been sent in if yeah,
let's just take 2 or 3 strategic ones that don't make us look too stupid, okay?
Well, it's hard to sort through them. There's so many, but why don't we just, Lauren, you want to read just one off the top?
Sure. So one question came in. Can a morbid obesity IBC-10 coding from weight and height data of BMI only and collected by a medical records person and request to MD for diagnosis or requires more documentation in medical records?
Okay, so I think this question is related to the ICD-10 coding, and I think if I understand the question correctly, Clint, I'll take this one if you don't mind.
Sure.
I think the answer is the ICD-10 coding can support that classification. However, I think what you're getting at, and rightly so, is documentation needs to be there to back up that ICD-10 code. But if that isn't exactly what you intended in the question, you can email us, and we'll be glad to clarify it. One more.
Sure. Another one came in. The question was, active diagnosis will still be in the last 7 days. So for example, if malnutrition is ICD-10, for malnutrition must be active, correct?
Chris, do you want to take that maybe? Or anybody? Yeah, I think the answer would be it would need to be the active problem at the time of admission to drive that payment. So again, if that's what you expected, and I'm getting your question right, you can accept it. If not, send me an email. We'll be glad to clarify it.
Okay, Lauren, we'll take one more question.
Okay, perfect. So one other came in. Since CMS is supporting REG through financial year 2020, can managed care remain on REG for next year?
That's a managed care question. Susie?
I actually didn't hear that. Can you say that again, please?
Sure.
Right. So the question is, since CMS is supporting RUG through financial year 2020, can managed care remain on RUG for next year?
Yeah, absolutely. If our facilities are going to complete RUGs, MDSs, and they are going to get RUG scores, absolutely. They can go as long as we're going to be doing RUGs and as long as we want to be doing RUGs and need to be doing RUGs. So yes, they can.
One caveat that we don't want to get into on this seminar, but you understand that many of the Medicaid systems are tied to RUGs, and that's going to be changing for your state reimbursement systems soon. So just so everybody knows that.
Right.
The feds are very interested in integrated reimbursement plans and have never liked 50 different reimbursement plans on Medicaid anyway. So, but anyway, that's for another time. We've got to get PDPM in place for Medicare to start with.
Sorry, this is Cheryl. I just wanted to add to that. Just, keep in mind under PDPM, you're going to do that one admission assessment and a discharge assessment, potentially an interim payment assessment. So you'll have a lot less opportunities for communicating in RUGs in other payment models that would otherwise take RUG scores from the past. So I think we have to look at what that change might mean in your other payment models.
Very true. So that's just a teaser of the type of questions that are coming in. You guys might have a feverish bunch more questions you want to send to us. We will get you back answers. Lauren's going to make sure that everybody gets a copy of the recording here for your use, and the answers to the questions, we'll try to get those back to you as soon as we can. Our panelists are committed to getting you hopefully good answers soon, and the key word is good answers soon. And you also will be having information sent to you about the panelists in case you need to contact any of them individually in addition. Thank you again for your time. Thank you for Grassi, Love Funding, and of course my company, Mount Lemke, for the sponsorship. Thanks for the panelists, and thank you guys for being on today. Take care.
Great.
Thank you.
Got the recording?